I'm Laura Serbu. I'm an internal medicine physician. I'm also a preventive medicine trainee. The presentation will be both on asthma and chronic obstructive pulmonary disease, but it'll be more like 2/3 asthma, just as a heads up. The topics will include asthma as a comparison to chronic obstructive pulmonary disease. We'll also be discussing some environmental risk factors, in particular for asthma, as well as some ways to prevent asthma flares or exacerbations. And lastly, a brief comparison between the different types of medications for these two conditions. Essentially, asthma is a condition where there's limited airflow going in and out of the lungs. And this can look like in a person, whether they're wheezing, coughing, shortness of breath, maybe some chest tightness, just overall difficulty breathing. And this condition is usually diagnosed in a child, while chronic obstructive COPD, which I'll just say COPD moving forward, COPD is diagnosed usually in an adult. But to confirm asthma, we usually do something called a pulmonary function test or a PFT, just to get a sense of how the air is moving through the lungs. Usually it's a test where someone's like breathing in a tube and getting a sense of, like I said, how the airflow is moving, maybe even seeing how that airflow is moving in response to a medication, things like that. So I really like this diagram, kind of showing like if you looked at our breathing tube going into the lungs and kind of taking a section of that, kind of like looking through the tube, essentially a normal airway that you can see down here on the right. It's open, there's no obstruction to the air or difficulty in the air going in and out, while the asthmatic airway, there's like some constriction, or as it says here, the airway is tight, so it's difficult for the air to move in and out. For COPD, however, similar idea, but a little bit of a different process. So the foundation of it is the same. Air is having difficulty moving in and out of the lungs, and that can show up as shortness of breath, but more so for COPD than asthma, but it can happen in asthma as well. But there's usually a cough, and it can have phlegm or sputum as well. I mentioned that it's diagnosed as an adult, and the risk factors for COPD is the main one actually is smoking. So tobacco smoke, cigarette smoking. I put also smoke there as the next one because globally there's a lot of places around the world that burn wood for cooking, for warmth, even wood burning stoves, things like that. And that smoke is also a main risk factor for COPD. Seen a little less in the United States, but still applicable. Smoke in general really irritates the lungs and can cause damage over time. If someone is an adult who was diagnosed with asthma, that can also be a risk factor for COPD, as well as family history. Like if there are other people in the family that have this condition, seems to be a family history component of it as well. Same with asthma, like the pulmonary function test, getting a sense of how the lungs are working, how the air is moving through the lungs is part of the diagnosis, part of the way to confirm that someone has this condition. And these photos or images that I have here are, this first one is of the lungs. So as I mentioned, there's the breathing tube that goes down, how we get air in and out from our mouth into the lungs. And that breathing tube actually separates into two for the two lungs. And then it continues to separate smaller and smaller and smaller until it reaches all of the parts of the lungs. And when it gets to those, I guess, the end part of the lungs, what you can see there is something called alveoli, which is shown here on the right. And I kind of think of it as little pouches where the air comes in, and around the alveoli is blood, like little blood vessels. And that's where the magic of the lungs happen, where the blood takes in the oxygen, releases the things that we don't need in the body, essentially carbon dioxide and other things. And so that's where the magic happens. And that's where the lungs do their job of us taking in oxygen that we need, and then we exhale carbon dioxide or CO2. Unfortunately, smoking or smoke in general, for example, can irritate those pouches and different parts of the lungs as well, and can over time honestly destroy that structure that's set up. And so a big distinction between COPD and asthma is that destruction over time due to smoke kind of causes the lungs to not retain their shape as well as before. And then the lungs kind of get bigger, and it's hard for them to move in and out and kind of get bigger and smaller with breathing. And so that's part of the obstruction kind of that we see with COPD. It's harder for the lungs to move move in and out like they used to. And so then there's difficulty breathing thereafter as well. The parts of the airways that are affected in asthma are in the bigger parts, for example, more often than not. And totally right for COPD, it's more in the smaller parts. However, if someone has a lot of phlegm or sputum, those things can kind of build up and kind of affect the airways that are bigger as well. But like that destruction and irritation of the lung, the parts of the lungs that are in the smaller parts is more for COPD, a little less so for asthma. Another example that I heard in my medical training was that someone compared the lungs for someone who has COPD like a plastic bag. So if we just kind of think like a plastic grocery bag filled with air, like that plastic bag is not really getting smaller and bigger with ease. It's just sort of like stays kind of big and filled with air, and it doesn't have a lot of structure to it. And that's kind of what's happening over time with the irritation from the smoking and the smoke that can happen. It just really destroys the structure of the lungs, and then it kind of turns into this plastic bag that can't really like go in and out easily. Someone like me being a preventive medicine physician as well, I like to think of things before the medications, before some treatments, like what can we do in the environment that we're living in or what we're doing to try to reduce symptoms, reduce exacerbations, reduce discomfort. And some of those things are in image form here. So, and these are in particular more so for asthma, but some of these can be COPD related, but mainly for asthma. So we kind of think of things that can irritate the lungs. And for people living with asthma, that level for irritation might be different than for someone without asthma. So say if someone doesn't have asthma and doesn't have allergies, you know, the pollen around them doesn't bother them. They can have dogs and cats, doesn't bother them. But for someone living with asthma, they may also have allergies. And so when either or is affected, it can kind of flare up the symptoms. So things like mold can be irritating, cockroaches, rodents. I mentioned pollen as well. Some people can have allergies to cats or dogs. And then things more broadly speaking, like in the environment, like pollution, even at times heat, humidity can cause different, you know, for different people, irritate the lungs in different ways. And last but not least, smoking, the smoke from tobacco, even from marijuana products can be irritating to the lungs. And so with that in mind, if someone has exposures to any of these things, it can be really helpful and very beneficial to target those first, see how someone kind of settles after getting those things addressed, and then discuss some medication changes if needed, for example, along the way. For example, if someone has allergies and they also have asthma, it's important to talk about, you know, how are we addressing those allergies? If you are really sensitive to pollen, are you potentially like wearing sunglasses when you're outside and you take a shower every day to just like get the pollen off of your hair and your body? And, you know, when you get home, changing out of those clothes so that the pollen's not on your clothes, things like that, that can actually make a difference. And of course, if someone needs allergy medications to get them through, that's something else to discuss. If there are housing issues, contacting 311, getting in touch with the super. And at times in the past, when I was in my residency training, like I've written letters, which I don't know how helpful they can be, but it could be helpful to say like, this is a letter from my physician. I have asthma. This mold needs to be addressed right now. That's an option. I know this isn't available or possible for everyone, but if there's an option to change out flooring, or, you know, if you're switching up housing to get flooring that's not carpet tends to hold on to dust mites and things longer than just flooring that's not carpet. I acknowledge that that's not a possibility for everyone, but just letting you know of that information. If someone has asthma, it's important to not have cigarette smoke, marijuana smoke nearby because it can be very irritating. Something that is less talked about, but also one of the things that can affect the lungs are actually perfumes, cleaning sprays even. And so if one is using cleaning sprays in the home, it's good to, if possible, to keep the windows open, keep the door open, just getting as much air in and out so that those sprays don't linger in the air. Also, if you're using cleaning spray, something that's not really considered is that instead of spraying it, if I'm cleaning a mirror and I'm just kind of spraying all over to clean the mirror, instead of doing that, you can actually spray into the cloth and then wipe down whatever you're doing. Spraying into the cloth really reduces the spray being in the air. So that's like a quick tip that could make a difference. Ventilating. We talk a lot about pollution outside the home, but actually inside the home, pollution can kind of exist too. And it's something that has been brought up more and more, I think, with some of the wildfire smoke that's been going on last summer, and even with related to the COVID pandemic, this concept of ventilating the indoor spaces has become more and more important. I don't know what type of phone people have and what type of apps people use for weather. I found out within the past year that the iPhone weather app actually has a section on air quality. And so that's something that sometimes I look at for myself. Certainly it was helpful when the wildfire smoke was coming through to have an idea of like, what's the situation out there? What's going on? There are days when it's a good time to open the windows, but unfortunately there are days when it's not a good time to open the windows. So for example, if the pollen count is really high and someone with asthma has pretty severe allergies, good to keep the windows closed. But if there's not a lot of smoke, not a lot of pollen out there, then maybe it's a good moment to just open the windows a little bit and get some air in and out of the home. Last but not least, just talking a little bit about medications for asthma. As we can, it kind of makes sense, like we're trying to target the lungs. So the way we get medications into the lungs is through usually inhalers. But there are a couple of medications that can affect, for example, allergies and other things that we take by mouth, but generally speaking, for the lungs, for asthma, we're talking about inhalers. The kind of blurry picture on the left here is Symbicort, or I won't go through the generic name, but I put this here, and the next one here, albuterol. I put albuterol a little bit lower. That was intentional. I know the photos look a little erratic, but I put it a little bit lower because albuterol has been falling out of favor a little bit for like a rescue inhaler for asthma. And actually Symbicort, or a similar medication to Symbicort, a similar combination of medications, has been recommended as sort of first line for someone to take. So if you are living with asthma and you're starting to get a little bit of symptoms, you can use it as needed. And then after a certain point, if things get worse, you can start taking it every day. And that's sort of this small graph here on the right. The intention is not to like focus on it, just to say that with asthma, we actually increase medications if someone's symptoms aren't doing too well, if someone's feeling worse. And then once they're doing better, we can actually come down and decrease it. So it's a little bit of a dance. And like I said, part of that discussion is talking about environmental risk factors and addressing those. And maybe in the springtime, someone with the pollen, someone's asthma symptoms are really getting worse. And so we'll increase the medication, but summer and fall, winter, they do better, we decrease it. For COPD, the medications are slightly different. There is quite a bit of overlap. I don't mean to say that they're totally different. There's some overlap, but we target different medication classes, I guess. And similar to asthma, there's this sort of stepping up of medication intensity if people aren't doing so well. But different to asthma is that we don't tend to fluctuate too much. We kind of try to figure out something that works for that person so that their symptoms aren't tolerable. They can get through their day, they can get through their life, but it doesn't change so much as it can for asthma. But similarly, there are different options out there. On the plus side, as time has gone on, a lot of these inhalers are combo medications. So this inhaler here on the right actually has 3 different medications in it. So that makes it nice to not have to take like 3 different inhalers. It's just like all in one go. We're finding out more and more that there's quite a bit of overlap between COPD and asthma in the adult realm. When you have asthma, like some things I think about, which doesn't have to be the case, but some things I think about is, are any of these symptoms worse at work? Is this somehow a work-related asthma, or like different chemicals or different things? But the reason why asthma is more common in kids is just because of their size, like the size of their body, the size of their lungs, like the way, growing. So that's why some people say like, oh, I grew out of my asthma. And that can happen, like you have asthma as a kid, and then as an adult, you like don't need inhalers, you don't have a, trouble breathing, things like that. That can happen too. And there's also like someone who didn't have asthma as a kid. It is a possibility of diagnosing it as an adult. And that's where the pulmonary function test or the PFTs, that may be part of the diagnosis. It's just important because the different results point to asthma or COPD or both.
And when you're treating somebody who has COPD and asthma, do you do treatments for both? Like, how do you treat if somebody has both?
My approach would probably be like, okay, getting a sense of when the symptoms happen, where does it feel like, what is pulling the symptoms more? Is it more COPD? Is it more asthma symptoms? Certainly if someone's smoking and counseling to quit smoking, I think I would probably target the COPD. And if there are certain flares, see what kind of rescue inhaler works better for them. Is it more of a rescue inhaler that aligns with asthma, or is it a rescue inhaler that aligns more with COPD, and kind of working with the patient to see what works best for them?
if they're on a regimen and their symptoms are under control, then that's the main sign that they're on good medications. Albuterol, that is becoming a little less in favor and something a lot of patients really love because it really opens up your airways, but it doesn't really address the inflammation. So that's kind of the idea that some of the like steroid inhalers that like Symbicort, which like steroid sounds like scary, but it's not. It's actually like really beneficial for asthma and for certain other diseases, of course. That's like that inhaler can actually address some of the inflammation that's in our airways. So making sure like you definitely don't want to be using albuterol like multiple times a week. So if that's ever the case for you, making sure you're actually being evaluated to get other medication that can actually treat you rather than just kind of like give symptom relief. And if like for a combination of COPD and asthma, and for a lot of these diseases, it's about kind of getting the right medications that work for you. That even like using a mask and stuff while cleaning, or like if there's a lot of perfume around, and like just thinking about what we are inhaling and the ways that we can prevent it. So masks can be really useful in those settings, and at work too, and thinking about if you're exposed to a lot of things in the air, or feel like there's dust or anything in the air while you're working, that masks can be really helpful, even if you don't have asthma or COPD, at just like preventing those from irritating your lungs.
Unfortunately, some of the molecules that kind of happen from sprays or pollution and other things pass through masks. So masks can prevent some parts, but unfortunately not everything. And the ones that can really prevent everything are like those really big, like industrial, like filtered masks that are like thousands of dollars. So not to be a Debbie Downer, but just to share some of that information on like the details of it.
What are your sort of tips as far as vaccination goes for RSV, for flu, for COVID, for people who have asthma or COPD?
Yeah, my recommendation is that vaccines are very effective and fortunately even more helpful for people who have COPD or asthma. Like if someone has COPD or asthma, their lungs are already irritated, or the inflammation is going on. And so vaccines are even more important for that subgroup of people to prevent, like a worst case of the flu or RSV or, COVID, or the things that you just mentioned.
Get vaccinated. The ongoing message here.